Dear colleagues, welcome to today's webinar on use of non-vitamin K oral anticoagulants in AF patients undergoing cardioversion. I'm Stefan Hohnloser. I'm a professor of cardiology at the Johann Wolfgang Goethe University in Frankfurt, Germany. The aim of this webinar is to understand when and how a patient treated long-term with a NOAC can be safely cardioverted, how to initiate NOAC therapy in an oral anticoagulation naive patient who needs cardioversion, and to understand the role of TEE in a NOAC-treated person undergoing cardioversion. We will examine these questions by discussing pertinent clinical case scenarios. These cases will be presented by Professor Tatjana Podpara, a cardiologist from the University of Belgrade, Serbia, and by Professor Hein Heidbüchel, a cardiologist from the University Hospital Antwerp in Belgium. Welcome, both of you. This session is thought to be highly interactive, and we strongly encourage you to actively participate by sending your questions and your comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessments in the form of multiple choice questions that will be submitted during the presentations. Anything you need to know, just ask and we will provide tips and tricks wherever we can for your daily clinical practice. This webinar is possible thanks to an educational grant from Pfizer. Now I will hand over to Professor Heidbüchel to present the first case scenarios. Hein?
Good evening, Stefan. Good evening, everybody. Before starting, I will quickly show my disclosures. I have worked as speaker and consultant for all NOAC companies. I think that's well spread over the industry. Since my election as EHRA president, I only take one symbolic euro as personal honorarium. I think we all agree that cardioversion for atrial fibrillation creates a risk for thromboembolism, for stroke or for peripheral embolization, and we all appreciate for long already that oral anticoagulation has a role in such a situation. This dates back to data from even the 60s last century, and to show you just the latest data from the Danish nationwide registry published 2 years ago, you can see that those patients that were cardioverted here in red without oral anticoagulation management around the cardioversion had a clearly increased risk for thromboembolism associated with that cardioversion. So I think we all agree on that. But nevertheless, we appreciate that there are different scenarios. And that's exactly what we want to discuss with you tonight. That is to go over different scenarios. We have once looked back in our hospital at patients presenting for cardioversion, and as you can see here, about half of them are patients that are already for a longer time on anticoagulant treatment or anticoagulant treatment with the non-VKA oral anticoagulants now in chronic treatment. But some patients, as you can see here, 16% present to the emergency ward for cardioversion with an AF which is more than 48 hours of duration without any background long-term anticoagulation. And finally, there is a subgroup, a sizable subgroup, as we noticed in 30% of our patients that present with new onset AF, less than 48 hours of duration, and that do not have anticoagulation on board. Most of these AF patients, of course, have an increased CHA2DS2-VASc score, and we will go over these different scenarios here on how we deal with anticoagulation around cardioversion and more specifically anticoagulation with NOACs. Let me first present you Helena, who is an 83-year-old lady with a number of risk factors apart from her age, as you can see here. And she has a history of AF since 10 years, which comes back from time to time, less than once per year, but each time is associated with heart failure, and therefore cardioversion has been performed already a couple of times. Helena has some cognitive decline, and for that reason she has been admitted to a nursing home where she lives for the last 3 years. And over the last 6 months she was switched over from vitamin K antagonist to a NOAC, a drug which is presented to her together with other medications by the nursing staff on a daily basis. Now she presents to your emergency ward with another bout of persistent atrial fibrillation ongoing for 3 days. And so the question then to you, of course, is, do you cardiovert Helena? Do you proceed as such? Or do you say, no, I want to change the anticoagulant regime first? Do you opt for a TEE, and do you think that's really required? Or do you think that it's not meaningful to do a cardioversion given her age and her recurrent episodes of AF? The choice is up to you.
Hein, while the audience is voting on your question, there's already a question coming in. This is an 83-year-old lady. Any age limit for NOACs in this population of AF patients?
No, there is no real age limit. Of course, the information we have in the very old age groups is limited, but the information we have so far proves that the efficacy and the safety benefit of NOACs compared to VKAs also applies to these very old people. So I think Helena rightfully deserves a NOAC. Yeah.
Very good. So the audience says that the majority actually says that you would cardiovert, but only after a transesophageal echo. 41% of the participants voted for that, whereas yes, I cardiovert her without TE, that is the implication, 26% of the audience.
Yeah, that's intriguing, and we will see why that's intriguing, because in fact she is under stable anticoagulant therapy, which was given to her, as I told you, by the nursing staff. And we have a vast number of data sets now to show that in such patients you can safely proceed even without a TEE. Let me quickly go over the data we have so far. From all the four phase 3 trials with NOACs, we have observational data on cardioversions. On this slide, for instance, you see the data from the RELY trial with the bigatran, where about 2,000 patients required cardioversion over the course of the trial. And as you can see, the event rate pericardioversion for thromboembolism was very low and is not different in those patients that were treated by the bigatran compared to those on warfarin. We have similar observational data from the ROCKET AF trial with rivaroxaban. The number of observations is smaller. As you can see, the rate of thromboembolism, this was a high-risk population, as you know, in ROCKET AF, was slightly higher, but was definitely not different for those patients treated on a long-term basis with rivaroxaban or with warfarin. Another trial with apixaban, the Aristotle trial, observed 750 cardioversions. As you can see here, a very low event rate in this population without any strokes, nor in the warfarin, neither in the apixaban groups, as you can see here, and also the bleeding profile was exactly similar. And more lately, we have also now data from the ENGAGE AF study with edoxaban, again 630 observations on cardioversion with very low event rates of stroke or systemic embolism in the VKA group, the high dose regimen, which is the approved regimen for edoxaban, and maybe two here in the low dose regimen, but that is numerically, not necessarily statistically relevant. But all observational data that are very consistent in the sense that patients that are treated on a long-term basis can be cardioverted even without the TEE being performed in these patients, just as we proceed also in patients that are under VKA therapy.
So let's clear about this, Hein. This is, imaging is not needed if a patient is for a prolonged period of time on anticoagulation, being it a NOAC or a VKA. That's the take-home message.
I will come to your question immediately because there's some nuance.
Okay.
And let me first go over some more recent prospective trial data that also somehow indeed confirm this theme that in a patient that is on NOAC for more than 3 weeks and is in need for cardioversion, you can proceed without a TEE. We have data from 3 trials that randomized patients to VKA or a NOAC, and then looked at the outcome around cardioversion. The first trial was EXVERT with rivaroxaban, and as you will see in the other trials, some patients were anticoagulant naive, 57% in this trial, others were experienced, and also these trials made different distinction between 2 scenarios, one with a direct cardioversion, an early cardioversion, and one with delayed cardioversion, which is the topic I zoom in here, where patients were treated for 3 or more weeks with an anticoagulant. And in this time, it was randomized rivaroxaban versus VKA. And as you can see, the outcome, again, in this prospective trial for thromboembolic events was very, very low. It was not different for rivaroxaban versus VKA, and the results were also independent from the arm, the early or the delayed cardioversion arm. Similar data with edoxaban in the ENSURE-AF trial, a trial which was presented in 2016 at the ESC Congress. As you can see here, 46% of this population was randomized to delayed cardioversion, so 3 or more weeks of pre-treatment with VKA or with edoxaban. And again, the composite outcome, which was thromboembolism, was similarly low in the edoxaban and the VKA treated groups, and also independent from whether a TEE was performed or not. And more recently, at the ESC meeting 2017, we heard the results of the EMANATE trial, a trial with apixaban, comparing cardioversion with apixaban to heparin VKA. Interestingly, all these patients were new to anticoagulant treatment, but again, the efficacy outcome of stroke and systemic embolism was very low. It was even statistically lower here in the apixaban treated patients than in those in the heparin VKA, and again, this was true in both early and delayed cardioversion arms. So this brings me to a second case, and also to the remark, Stefan, you made before. This is Arnold, a 60-year-old professor emeritus who is still teaching a lot and traveling around the world. He has hypertension and a history of paroxysmal AF since about 10 years, for which he gets flecainide and beta blockers. And when he turned 65 a few years ago, he was put on a NOAC. Apparently, he's been taking this for 4 years. Like Helena, the 83-year-old lady, he presents to the emergency room with atrial fibrillation, this being his first bout of persistent AF. It's not paroxysmal, it's not stopping apparently, it's going on for 3 days, and Arnold wants to get rid of it and presents for cardioversion. And so the question again to our audience is what they would do with Arnold. The same sort of options. Will you immediately cardiovert him? Will you change your anticoagulant regime? Will you require transesophageal echo here? Or do you think it's not meaningful in Arnold to do a cardioversion?
So we will see what I said, whether or not this makes a difference, right?
Probably option 4 will not be chosen here.
Not meaningful given age and recurrent AF. Yeah, I believe so. Less of
importance here. It's the first episode of persistent AF, so he definitely deserves a cardioversion.
Yes. Irrespective of age, of course.
Yeah, he is on a NOAC.
He's symptomatic.
And he's symptomatic, definitely.
Yeah.
So
the question of adherence is what is all behind this, right?
Yeah, and we will immediately come to that, and I'm curious to see how our
audience is thinking about
answering. Yep.
So the majority, almost 2/3 of participants say, yes, you can cardiovert this gentleman. Hein, what do you say?
Well, this is very intriguing because this is a younger man, and here most would say, yes, I cardiovert immediately, whereas in our older lady, they would prefer TEE. So apparently our audience chooses for the TEE based on the risk profile, an elderly lady with a higher CHEDS-VASc score,
interesting observation,
rather than on the treatment behind, which is here the NOAC treatment. Now, I brought up this case, of course, as you mentioned, for the adherence issue, because I left that aspect intentionally out of the flow chart in my prior slides. This is the flow chart, by the way, of the EHRA practical guide that many of you may know, and that's in the works for a second revision. But in that flow chart, you will see that if a patient is on a long-term treatment with a NOAC, that adherence indeed is important. Before you cardiovert, you should inquire about the adherence. And if you think the patient is well adherent, yes, you can cardiovert. That's the data I've shown you from all the phase 3 trials where we know that adherence was high and very well checked. But if you have any doubt about adherence, and it may be that Arnold, although he is a professor, is not that adherent while traveling around the world. I don't know whether Stefan, you took your NOAC tonight already. But if you have a doubt, then the practical guide recommends you indeed to perform a TEE here because you want to make sure that he was that there is no thrombus. And that brings me immediately to my next question, because Arnold got a TEE, and as you can see, it showed a thrombus in his left atrial appendage. And so then the question again to you out there is, what now? Do you stick to your NOAC, tell Arnold you should work on your adherence, and you come back in a couple of weeks? Do you change your NOAC? And of course, may also be work on your adherence. Do you change to VKA now because you have seen the thrombus? Or do you say, regardless of the thrombus, I will cardiovert him, he wants to travel? Again, the choice is up to you.
So here we have already the answer of the participants, and 2/3 say stick to my NOAC, work on adherence. So they would not propose to change from one NOAC to another, or to change from the NOAC back to warfarin, heparin-warfarin combination, what have you. They would simply say stick to my NOAC.
Yeah, and that may be a reasonable choice, although we have to admit that we still do not have overwhelming amount of data.
It's almost a data-free zone, I would say.
It's almost data-free, but not entirely data-free, and I will show you. It definitely is not wise to cardiovert. The guidelines, if you can read this box here in the flow chart, tell you that you should not do a cardioversion. You should postpone it. You should have a longer period of anticoagulation of at least 3 weeks, and then do a repeat TEE before you consider any cardioversion. But the guidelines will mention, and also the practical guide indicated that we don't know what is the best strategy, honestly. Should you convert to VKA and INR-based management, or should you continue your NOAC? We have some data, and I will show you. There is the EXTRA trial with rivaroxaban, which in fact is not a real trial in the sense that it is a single-arm trial, so not randomized, in patients that had a thrombus, like our Arnold case here, and that were or naive to anticoagulation or had VKA, which was not well managed, and that may have been the explanation of the thrombus. And in EXTRA, 60 of those patients were put on rivaroxaban and followed up for 6 weeks. And the investigators found that around 40 to 60%, depending on how you defined resolution of the thrombus, had effectively resolution under rivaroxaban. But that is not randomized. If we look at historical controls with VKA, you are around the same percentage, which looks reassuring, but it's not randomized. There is a randomized trial going on with dabigatran versus VKA in this context, and I think this is data we definitely want to see. As you mentioned, this is an almost data-free zone. But there is also some data from the EMANATE trial that I just mentioned to you, the trial that cardioverted patients randomized to apixaban or VKA, and these patients could get an image-guided, a TEA-guided cardioversion. And in 840 patients, a TEA was done in the trial, and in 61, a thrombus in the left atrial appendage was found. And interestingly, this was spread evenly over apixaban-treated and heparin VKA-treated patients. Of course, these patients were naive when they entered the trial to anticoagulation, and that may explain why it is the same in these groups, because they were not treated yet. They were randomized to the treatment then. And interestingly, when you follow these patients, the majority of them had indeed a repeat TEE after about a month or more, 37 days, and that was the same in the two arms. And if you look at the small numbers here, and unfortunately this is only from the presentation at ESC, we don't have the manuscript yet, but it looks like about half of the patients have resolution of the thrombus, both in the apixaban-treated group as in the heparin VKA group. Here you can see 8 out of 18 versus 10 out of 18, which is about half. So this indicates that probably there is equivalence in dealing with these patients for treating them with NOAC and maintaining good adherence, as our audience opted for, or going back to VKA. So that's for the scenarios I wanted to discuss, and I'm happy now to listen to Tanya, who will discuss patients that are not yet anticoagulated and need cardioversion.
Thank you very much, Hein. That was very enlightening. Before we go to the second presentation, I have one question here, which is directly related to the last point we were raising. What about if the thrombus is still present after 3 weeks of reliable anticoagulation? What then?
Again, the same zone where we don't know. I think most of us would prolong even the phase where we wait and anticoagulate. Whether you should switch over there again, I don't have the answer. Whether it's better to go to VKA, there is some argument for VKA because, as you know, it will have a wider impact on the coagulation system by inhibiting different coagulation factors rather than blocking one factor. So there may be something to say for going.
But that needs to be shown.
But that needs to be shown. I would definitely prolong. If, of course, after multiple weeks you see the same thrombus, then you can think that this may be an organized thrombus, may be less of a risk of embolization around cardioversion, and then you have to weigh the pros and cons to cardiovert.
Exactly.
And perhaps,
very good.
Perhaps patient preferences too.
Yeah, of course.
Yeah.
Of course, patient preference is very important. Another question which is more or less directly related, any risk factors for finding a thrombus if you decide to do a TE?
I think these risk factors are related to the CHA2DS2-VASc score, so to say, or the ABC score if you want to use another score. I don't think there's a specific risk for a thrombus related to the overall thromboembolic risk.
Very good. Tanya, the floor is yours.
Well, thank you, Stefan, Hein, and good evening to our audience. Let's go with the next patient. That would be a 71-year-old female patient complaining of fatigue and palpitations for a week or so. Now she's diagnosed with first onset atrial fibrillation of unknown duration, but most likely her atrial fibrillation is not lasting longer than for a couple of weeks. She also has a well-controlled hypertension, and so far she has never been taking anticoagulant therapy. So we have here anticoagulant naive or anticoagulant inexperienced patient. The lady is symptomatic. She plans to travel soon and complains of symptoms. In line with her preferences, we decided to go with cardioversion. And now the question for you would be, which cardioversion strategy would you consider for this patient. Either early cardioversion without anticoagulant therapy or with anticoagulation, or a delayed approach with at least 3 weeks of effective anticoagulation before cardioversion, or with either vitamin K antagonists or a NOAC. Please vote now.
So this is an elderly lady with, say, atrial fibrillation lasting for a few weeks, right?
Yes.
So probably the first option is not really an option.
Of course.
on that. We will see what the audience thinks about the others, right?
Yeah.
Yeah, maybe more than one.
That was just a
Correct.
teaser.
Yes, of course.
I don't know whether those that have pushed one can still correct themselves.
At least I gave him a chance. Okay, and here are the results, and the vast majority says delayed cardioversion after more than 3 weeks of anticoagulation with a NOAC. That's
wow.
almost 63% actually.
More than half of the audience, suggesting that 3 week of effective anticoagulation is still perceived as the safest way through to overcome the thromboembolic risk associated with cardioversion. Provided that we opted for an early cardioversion, would you, for this patient, consider an imaging guiding strategy using, for example, a TE to exclude atrial thrombus before cardioversion? Please vote one more time.
Yeah, I'm somewhat amazed that the majority would not go for the early cardioversion.
Yeah.
And the lady is symptomatic and she
And wants to travel.
She wants to travel, so delayed cardioversion is not her option, most likely.
So here there's overwhelming agreement, I'd say. 82% of the participants say yes. If early cardioversion is attempted, I would definitely do imaging by TE in this lady. Tanya.
Well, this is quite in line with the current ESC guidelines on AF management. Just as a brief reminder, current guidelines recommend starting a heparin or a NOAC as soon as possible before every cardioversion of atrial fibrillation, and then you can choose either an early approach with early cardioversion using a TE to exclude atrial thrombus and go for with cardioversion, or you can use a delayed approach with at least 3 weeks of effective anticoagulation before cardioversion. All those alternatives are recommended. Now let's review very briefly the evidence supporting these recommendations. Our anticoagulant naive patient with atrial fibrillation lasting more than 48 hours would nicely fit into the ACUTE study, for example. The ACUTE study randomized patient to a conventional delayed treatment strategy versus an early TEE-guided cardioversion and compared thromboembolic events during an 8-week follow-up. And the study showed that thromboembolic event rates were low in both treatment arms and with both with anticoagulant therapy, whilst in the early TE-guided treatment strategy, the rates of major bleeding were significantly lower than in the delayed conventional treatment strategy. Therefore, the ACUTE study suggested that a TE-guided early cardioversion could be or may be a clinically effective alternative to delayed traditional conventional delayed cardioversion. Now, how about NOACs in this setting for patients who are anticoagulant naive? As Hein already mentioned, there are post hoc analyses of the landmark NOAC trials. In addition, the 3B prospective randomized studies have been completed comparing the efficacy and safety of the rivaroxaban, edoxaban, or apixaban against the VKA for patients undergoing cardioversion. And these studies included overall slightly above 5,000 patients, but still these are only exploratory analysis. As a properly powered non-inferiority trial, for example, would require about 20 times a larger cohort than those cohorts, which is very important. All these studies included a proportion of anticoagulant naive patients, and indeed EMANATE's study with apixaban included only patients who were anticoagulant naive. If you look at the events overall in all of the three trials, you can see that both the rates of primary efficacy endpoint of thromboembolic events or cardiovascular death, or the rates of primary safety endpoint, major bleeding, or a composite of major or clinically relevant non-major bleeding, were low, comparable across all treatment arms in all three trials. Now, if we look specifically at anticoagulant naive patients shown in red bars, then you can see that in those patients, the rates of both efficacy endpoint and safety endpoint again were low, comparable, though slightly higher than in anticoagulant experience group, were comparably low and tended to be lower with rivaroxaban as compared to the vitamin K antagonist in the EHRA trial. And similarly, in the ENSURE-F trial with edoxaban, again, in anticoagulant-naive patients, event rates were low and tended to be lower with edoxaban, as well as in the EMANATE trial with apixaban, again, event rates low and comparably low in all treatment arms. Interestingly, in the subset of patients receiving a 10 milligram loading dose of apixaban 2 hours before cardioversion, rates of major bleeding were low and were similar to those with regular apixaban dosing regimen. Also, with respect to the timing of cardioversion and the use of TE, there were no significant differences between the event rates, either efficacy or safety, and these data are not shown in the interest of time, so that all in all, available data suggests that NOACs are safe and effective alternative to vitamin K antagonists to be used either for delayed late cardioversion, then you have to make sure that adherence is good, or to be used for early cardioversion in patients who should then first undergo a TE to exclude atrial thrombus before cardioversion. Now let's go to another case, an apparently healthy 52-year-old male patient who has been diagnosed with first-onset atrial fibrillation just about 24 hours before the presentation in our hospital. He is highly symptomatic, has important business meeting next morning, wants to have a free afternoon to set up for the meeting. So which treatment strategy would you use for this patient? Would you cardiovert immediately without any anticoagulation? Would you cardiovert immediately using some anticoagulant? Would you use a NOAC and cardiovert several hours post a single NOAC dose, or you would go for a delayed cardioversion after 3 weeks of effective anticoagulation, or you would just wait and see for a while? Please vote.
So, Tanya, to summarize, it's a 52-year-old without any risk factors and AF for about 24
Apparently
hours.
healthy. Yeah, 24 hours.
So several options can be obviously elected, and I'm curious to see what the audience thinks about that. It's a good question, actually.
Again, the patient is in a hurry, but we must take care not to endanger the patient, right?
But this is obviously a very experienced audience.
Yeah.
42% of the audience actually have chosen Cardiovert more than 4 hours after a single NOAC dose. Quite interesting. Quite interesting. And the rest is almost an even split, except for option number 5, which is really not an option for this gentleman who is highly symptomatic. So this is interesting.
I also want to point out that 14% chose for option 1, and we have to comment on that later on. But maybe first you can continue with your slides, but we have to come back to that.
Yeah,
Yes, lots of topics to discuss.
And it's rising. So perhaps 1 in 6 to 7 colleagues would go cardioverting without anticoagulant
Let's keep
therapy.
that in mind. Yeah.
Now, provided that we opted for an early cardioversion, would you consider using a TE to exclude atrial thrombus before cardioversion is in this patient? Please vote one more time. Options are simple.
This is basically imaging-based cardioversion versus non-imaging-based cardioversion.
Imaging guided, yeah.
In a 52-year-old
Yeah, exactly.
with 24 hours AF and no risk factors.
And who is in a hurry again?
And who is
Okay.
So let's see.
So the audience says 52% vote for performing transesophageal echocardiography before cardioverting this, despite the fact that the AF duration is limited to 24 hours.
Yeah. And additional 25% would go for a TE only in patients with additional stroke risk factors.
Yeah.
Well,
now, before you go on, maybe it exemplifies the fact that in Western Europe probably there is a high availability of TEs.
That is a very important point, indeed. Indeed, there are countries where hardly any TEs are done.
is available.
We have to acknowledge this.
Yeah.
Well, as per guidelines, again, just as a reminder, early cardioversion can be performed without a TE guidance only when a definite duration of atrial fibrillation is less than 48 hours.
So, if I may interrupt you at this point, so the guidelines would actually say the same as 42% of the participants, right? Who would go for a cardioversion without TE.
Right. Right. But
Right.
the guidelines said before, and I mentioned that already, that for every cardioversion you should give as soon as possible
We both-
anticoagulation. Huh?
Yeah.
We both emphasized that because it should be emphasized many times. Well, interestingly, anticoagulation before cardioversion has never really been properly validated against no anticoagulation, and data are particularly scarce for patients with atrial fibrillation lasting less than 48 hours. There are some observational studies, relatively small, showing that if cardioverted without anticoagulation, patients with a short AF duration, less than 48 hours, have relatively low rates of thromboembolic events. However, of interest is to look again into the results of the largest among the observational studies, which included more than 5,000 patients successfully cardioverted without oral anticoagulant therapy, and those were patients with atrial fibrillation lasting less than 48 hours. Notwithstanding all limitations of a retrospective observational study, important finding in this study was that the risk of thromboembolic events with non-anticoagulated cardioversion of AF significantly increased if AF was lasting only more than 12 hours and was proportional to the duration of AF above 12 hours. And not only that, the risk of thromboembolic events increased with increasing duration of atrial fibrillation, but the same group showed that the risk of thromboembolic events also increases with several CHA2DS2-VASc stroke risk factors such as age, heart failure, diabetes, or even female sex. So the risk of thromboembolic events in patients with AF lasting less than 48 hours was increased in those with AF lasting for more than 12 hours or in those with additional stroke risk factors. And in the left-handed side, you can see how the use of oral anticoagulant therapy in low-risk patients with a CHA2DS2-VASc score of 0 or 1 makes no difference in the rates of thromboembolic events. Whilst in this retrospective observational study, the use of anticoagulant therapy made a significant difference in terms of significantly lower rates of thromboembolic events in patients with relatively short duration of atrial fibrillation, less than 48 hours, but with additional stroke risk factors. Therefore, as recommended in the EHRA's Practical Guide 2, when you have a patient with atrial fibrillation lasting less than 48 hours, then until more data are available, go with your hospital protocol, go for cardioversion, anticoagulate your patient with either heparin or a NOAC, and decide whether you are going to perform a TE or not. Thank you.
Thank you very much. That was a very concise lecture.
If I may,
Sure.
Sorry to interrupt, but if you go back one slide, and because you mentioned use the existing institutional practice, low molecular weight or unfractionated heparin, but also NOAC is there an option,
Yeah, I
right?
said
Of course,
the
yeah,
NOAC,
because okay.
I said the NOAC, it's not written,
Yeah,
but
okay.
that's what I said.
Sorry.
We have now almost 20 minutes for discussion, so I would like to encourage the participants to put their questions forward. We have already a good number of questions, and so let me start by a question for Tanya. A patient 45 years old comes to the emergency department for atrial fibrillation less than 48 hours and is cardioverted. CHA2DS2-VASc is 0. Should this patient be anticoagulated during the next month? That's a good question, actually. So no stroke risk factors, a young individual, 45 years, successfully cardioverted, maybe like an alcoholic excess or holiday heart syndrome or something like that?
Well, very interesting question, but if you weigh risks and benefits, but especially now when the management of warfarin has improved, when we have NOACs which are safer than warfarin, I would go for anticoagulant therapy for 4 weeks after cardioversion, because we do not know which is the shape and function of the myocardium, whether the blood flow was slowing in the left atrial appendix, so we know that thrombus may form also after sinus rhythm has been established, and the patient would be certainly safer with 4-week anticoagulant therapy.
May I ask you the same question?
Yeah, I understand.
I think it's an important issue.
Sure, I understand the question, because the argument sometimes comes up, if this patient would have spontaneously reverted, then the patient would not take 4 weeks of anticoagulation. Let me answer in 2 ways. First, the guidelines are very strict in this respect. They say that every patient that undergoes a cardioversion should be anticoagulated for 4 weeks, and longer if you have a higher CHEDS-VASc score, but at least 4 weeks. So the guidelines are very informative. But as you've heard, the data around it is sparse, and the data you've shown, observational data, show that especially in those with a CHEDS-VASc score of 0 or 1, the thromboembolic risk is very low. If you add to that a mechanistic view of why do you develop a thrombus, which is of course a part of it is stunning, and if the AF is short lasting, then maybe that stunning will not last 4 weeks. I understand why the question comes up, should we anticoagulate? But I fully side with you, Tanya, that there is factors that we probably do not know, in the sense that since the patient has persistent AF and requires cardioversion, maybe this is a risk marker for a wider cardiovascular risk and thromboembolic risk. And we know from other observational data that the AF episode by itself is not necessarily related to the thromboembolic stroke, but it is coming together in one patient. So I would stick to the guidelines, honestly, and I would anticoagulate for 1 month.
There's another question, and it's a good question, I think. The participant asks, how can you be sure about the hours duration of atrial fibrillation? And my experience in the clinical setting is that there are patients, they tell you precisely, yesterday at 5 o'clock in the afternoon, my heart went out of rhythm. And in that case, I think we can believe and we can trust the patient, and we can exactly estimate the time period. However, many patients are not able to do so. They would come to my office and say, for the last 5 days I have felt miserable. I'm out of strength, I'm fatigued, I cannot work. And if you ask them, and your heart rhythm, is it regular or is it irregular? They say, I don't really know. And in this case, obviously, you have to take a different view on the problem of cardioversion. Would you agree? Is that your experience as well?
I agree, and also there the guidelines are very clear. If you have AF of unknown duration, then you consider it as more than 48 hours, and you are in that part of the flow chart.
Right. Yeah. Exactly. Another good question here. The questions are coming in now. It's good. If a patient has doubtful adherence to a NOAC, what is the place, if any, I may add, for an anti-10A test for 10A blockers or a diluted thrombin time for dabigatran?
Maybe I can answer that.
Yeah, sure.
I don't think that plasma level determination is a way to measure or ensure adherence. And the simple reason is that they are too fluctuating to give any reliable long-term overview, and that's what you want to know with adherence. It doesn't go about one time point, it goes about every day and for weeks and months on a row. So plasma level determination will not be
factor 10A
solution.
test.
Yeah, whether it be with a factor 10A test or a diluted thrombin test, I consider those as measurement of the NOAC level. So I think adherence needs to be addressed by other things, and this is not a webinar about adherence, but I think education is key. We have also used electronic monitoring, and that publication will come to the European Heart Journal soon, in an advanced way by using it even in a telemonitoring-based daily feedback sort of system to optimize adherence. There you can know whether they take or not. That's not necessary for every patient, definitely not, but it may be of help in some.
I totally agree with you. I may just add another argument along those lines, which is that there's no study whatsoever showing optimized outcome if you measure anything, be it drug levels being 10A, whatever. In none of the studies this has been done. Tanya, there's a question for you. Is spontaneous smoke or contrast equal to LAA clot? I like that question. It's a good question.
Me too. Well, it is a risk factor for forming of the clots, indeed. Whether it's equally thrombogenic, well, data suggests that patients who do have a smoke or spontaneous equal contrast, so-called SIC, in the left atrium do have increased thromboembolic risk, but it's not really equal as a formed thrombus.
I would say the same thing.
In practical terms, when I see smoke and no thrombus, I would make sure the patient is well started on anticoagulation. As we mentioned, the 4-hour duration there definitely is important if you would do it with a NOAC, but even with low molecular weight heparin, it is the same. And if you go for an early cardioversion, you can then, I think, do it. It may be wiser, maybe in such a patient, if you can, to have a delayed cardioversion strategy. But we have no real data.
No data, yeah.
There's another patient scenario which one of the participants put forward. This is a patient with a previous history of a left atrial thrombus a few years ago, actually. And would you or would you not, 3 years later, and the patient is on oral anticoagulation with a NOAC, would you perform a TEE before you do this patient? Remember 3 years ago, LAA thrombus?
I would do, yes.
Yeah.
It's not because we've mentioned that in patients that are under long-term anticoagulants, you can safely anticoagulate, that some specific patient situation may change your mind. I don't think there's something wrong by doing a TEE if you suspect there could be a problem, like in this case. I think it makes sense.
Right. This is a question. We could have patients with asymptomatic stroke, a silent stroke, and atrial fibrillation. Do we need a brain imaging before we do cardioversion in these patients?
No,
we don't.
I don't.
Right? This is an easy one. This is an important question, and actually there are several similar questions along those lines. We have talked about the importance of adherence in a patient who is on long-term NOAC anticoagulation. Would you, if you talk to the patient about the risks and benefits of cardioversion, would you make a note in the consent form or in the chart of the patient that you have emphasized the importance of adherence to therapy?
Definitely.
Yeah.
It was also in the flow chart. If you have a patient on long-term NOAC therapy and you want to cardiovert, you do that after you have interrogated the patient about the intake over the last weeks, about the adherence, and you make a note in the chart. It was clearly in the flow chart. You state, okay, the patient was asked whether he or she was adherent. She stated yes, and that's why I cardiovert without TE. So definitely make a note, yes.
Very good. Tanya, any further thoughts to this?
Well, I agree with Hein. I was looking to another maybe interesting question. What about the use of TE before cardioversion in patients receiving a reduced NOAC dose because of the impaired
I was coming to that, actually. There are several questions about dosing of NOACs and cardioversion. Both of you.
You raised the question, you may ask.
Yeah, of course. But I would say that, again, we could use more data, but available data suggests that properly dosed NOACs, properly reduced dose with adequate indications such as renal impairment has the similar effects in terms of safety and efficacy as the full NOAC dose. So I would treat such patient with clinical indications for a TE. I would not think of TE only because the patient is receiving, properly receiving a reduced NOAC dose. What do you think, Hein?
I agree. At the other hand, I don't think it's wrong to do a TE. And if you feel a little bit insecure as physician and a lower dose may make you a bit more attentive, then if you have the availability, why not do a TE? I think we have to admit that this is one of the small disadvantages of NOACs compared to VKA, that is that we have some more uncertainty around what has happened over the last 30 days and how safely can I cardiovert against the whole drop of the advantage of NOACs, this is nothing, but we have to acknowledge it. And I don't think a physician should feel wrong by doing a TE when he or she feels uncertain.
And what if the patient refuses a TE because of the inconvenience and is renally impaired and is receiving a lower NOAC dose? Would you go for cardioversion?
Yeah, I agree with you.
Sure,
If it's
yeah.
a proper dose reduction, patient is adherent, then you can do it. Yeah.
I think it's important to perhaps distinguish between dose adjustment because of there are clinical characteristics which need dose adjustment or dose reduction without these needs for doing that. I think that is important. There's another very good question. How about patient with atrial flutter? Does the same apply to patients with atrial flutter, what we are discussing right now?
A simple answer, yes.
Okay.
In the absence of evidence.
True.
Very good, very good.
Limited evidence.
There is a question. I saw some patient with atrial thrombus formation under NOAC therapy and with good adherence. Would you switch to VKA, heparin VKA? We have tackled that before, I think.
Yeah, well, I think that's reasonable. If you are sure about the adherence, then I indeed would change, yes.
Okay, yeah. And perhaps the last question, because we are running out of time, I'll put that forward to both of you. What about pharmacological cardioversion? We were implying DC cardioversion the entire webinar long, but what about pharmacological cardioversion? Again, does the same saying apply to pharmacological cardioversion as for electrical cardioversion?
I'm happy you asked the question because we indeed didn't address it, and we have now drugs like vernacalant that can do very rapid cardioversions, and which may work in 50% of the patients where you give it. Yes, the strategy is exactly the same.
Yeah.
Tanya?
I agree, fully agree. There is a presumption that perhaps the risk of thromboembolic events could be lower, but there is no evidence to support such view. So I agree.
The very last question, and a very short answer, Hein, by you, AF ablation. Does the same apply about the incidence of clots in the left atrial appendage, and what should we do about that? It's a very broad.
That's
a very broad question. I must admit.
And there was a separate webinar on that, so I would have a look at that.
Okay, I'd say it's perhaps fair enough to say that we have for all of the NOACs except for edoxaban at the present time prospective trials, randomized trials, which indicate to you that the efficacy and safety of a NOAC is comparable to VK in the setting of atrial. Of AFib ablation procedures, and I think that is an important take-home message. Yeah. All right, I mean, this brings us to the end of this webinar. We are now approaching, as I said, the end. I would like to close this session by reminding some key messages for our daily practice. Number one, there is good clinical trial evidence that patients with atrial fibrillation can be safely and effectively cardioverted while on a NOAC. Number two, it is important to ensure patients' adherence with NOAC therapy before cardioversion in order to avoid gaps in anticoagulation. Number three, NOAC therapy has been proven to be safe when given for at least 3 weeks prior to cardioversion. We discussed that. And fourth, TEE may be performed prior to cardioversion in patients who wish to undergo rapid cardioversion. Tanya's patient had no time, remember, or in whom adherence to a NOAC is of questionable certainty. We will now close this webinar. Thank you to Professor Potpara and Professor Heinbüchel for being with us tonight. And they have delivered excellent presentations, as I think, and the discussion was enlightening. My thanks also go to Pfizer, who supported this webinar with an educational grant. We hope you, the participants, enjoyed this time with us. You will be able to view again this webinar offline in a few days on the ESC website. Thank you very much.